This is that story, started on treatment, usually with levodopa, sometimes a dopamine agonist. Fluctuations develop, we start to layer the medication, we get the fluctuations under better control. Maybe months or a year or two goes by, fluctuations start developing again, maybe some dyskinesias. And sometimes with layering the medications and fractionating medications, we can re-achieve this relatively consistent control for a period of 10, even 15 years. But usually by 15 years, that control will become much more inconsistent and much more unpredictable. And really by the time you get to this stage, where patients will have unexpected dose failure, where some days they'll have a day when they're good all day and then a day when they're bad all day. Tablet therapy is not going to solve this problem, and it's not going to get you back here. And that's really when we have a second tier of therapies that we can now deploy, which can give patients good control of their symptoms for another 5 to 10 years. So we'll talk about despondency at the end of a talk, but I think one thing to remember with PD is PD patients often depression and anxiety part of their condition, despondency can be part of it, but actually their course is often very long and you can achieve really good quality of life for long stretches of their PD. And I think that's really important to keep in mind because actually many people live very well with Parkinson's for very many years. This is this second tier of therapies. There's actually now, unbelievably, there's 4 of them. So we employ all of these therapies on this campus. In the public and private in a variety of different forms. This is apomorphine. It's an injectable dopamine agonist. It's a pump therapy. It's been around for about 30 years. When I was a fellow in the UK in 2000, we were already using this therapy. So after that, along came deep brain stimulation, which is on your far right. This is a therapy where we implant electrodes in the brain connected to a pacemaker. And that therapy has been around for about 25 years. We've been practicing this at North Shore Private for over 20 years now. People always still come to you and say, oh, this is like science fiction, but this is old news. The newer therapies, duodopa, it's a therapy where there's a PEG tube inserted. So this gets around the problem of delayed gastric emptying in Parkinson's disease. There's actually an extension that goes into the duodenum and the medication is delivered this way. This therapy really now is being replaced by the one on this one, second on your right. So this is subcutaneous levodopa therapy. It's been available in Australia only about 6 months now, but basically this gets an extra step. So here we get around the problem of delayed gastric emptying and gastric absorption. Here we get around absorption through the GIT altogether. And so this is delivered subcutaneously, and all of these therapies have been shown to significantly reduce off time, to reduce motor fluctuations, to reduce dyskinesia, and to improve quality of life. So we have this excellent second tier of therapies that are available to us to treat our patients. They require quite a bit of work. There's usually a very high level of resistance from the patients for making that next step. But these are highly effective therapies in patients who have got uncontrolled motor fluctuations and dyskinesias.